All right. Welcome, everybody, to the Excel in Your Future PT Career series. I think we're on over 14 now. Today, we're super excited to talk to you all about sports PT case studies. And our expert of the month is Kevin Poplawski. Kevin is from Emory, which is one of our Confluent Health partners, and he comes with a wealth of knowledge and many years of experience. So he got his Doctor of Physical Therapy degree at Temple University in 2006. He's had 7 years of experience at the John Hines Spine and Sports Center, 5 years of experience as a senior physical therapist in orthopedics at UNC Healthcare, and has spent the last 14 years at Emory, where he serves as the site coordinator of clinical education, so the SCCE. Some of you may even know Kevin. So very excited to have him today. Also, fun fact about Kevin, outside of clinic, Kevin has written and published 3 children's books. I'm obsessed with this. I have already told him ahead of time. You can Google it. They're available on Amazon. This is not a book tour, but I always think that's really neat and something that as I get to know more and more PTs, the things that make PTs really sustainable and good at what they do is they also have stuff outside of PT, and they flex that creative brain, and oddly that feeds even more creativity in what they do with their cases and their patients. So I think you'll see a bit of that today. So I am gonna kick it over to Kevin, and he's gonna walk you through some sports cases.
All right, thanks, Allison. I appreciate it. Yeah, I appreciate the introduction. 27-year history in physical therapy. I think 26 of the 27 years in orthopedics, sports medicine, ranging from some time in Pennsylvania, some time at UNC in North Carolina, and then, like Allison said, the last 14 years. I'm always busy. Like she said, I read some children's books. I do some travel agent work on the side. My wife is a busy physician, and we've got two daughters, and so I always feel like I have to stay busy, but I do enjoy the education aspect. I've been the site coordinator in clinical education at Emory Healthcare for about 8 or 9 years now, and we've expanded our programs out to many schools while I've been here, and we've had some great students come through and great students that we've hired on as physical therapists at Emory Healthcare. So I always say my grandfather moment is a student of mine who we hired on. We just hired one of his students on. So that was kind of like my grandfatherly moment in my PT career as a clinical instructor. So tonight I'm going to talk to you about some case studies that I went through that I've kind of thought about through the years of some of the decisions that I've made, and some, kind of the clinical pearls that I can relate to you and what can help you in your career. And please feel free throughout it. I'm going to ask for kind of pause to just think about some of the questions that I'm asking, and then I'll kind of reveal my clinical decision making through it. But if you have any questions in the meantime, feel free to ask away, and I'd be happy to answer either throughout or at the end of our program. So I have no financial disclosures. I wish at one point that I could have some type of conflict of interest or something like that, but nothing at the time now. So again, I said this is going to be decisions. Like, what have I noticed in some interesting cases? And some of them are high-level sports medicine cases. Some of them are your weekend warriors. Some of them are your high school athletes, and some interesting cases of as far as what direction did I take their care, and what was my communication with the other healthcare providers, whether it be a trainer, whether it be a physician, and things like that. So the first case, this was actually when I first came to Emory Healthcare, and I was shadowing with one of our physicians. I apologize for that. So I was shadowing with one of our sports medicine physicians, and we had a case that we went into, and this was a 17-year-old junior, high-level high school football player, committed to Tennessee, offensive lineman, and he had a shoulder subluxation. And so we kind of did the exam together with the physician. There was a trainer in the room. I was shadowing him just to get the idea, just to meet our physicians and get acquainted with them. And so when we stepped out of the room, we had more of a discussion. And so when you're thinking about these high-level offensive linemen, football players, what do you think of as far as the subluxation? Are they more posterior or anterior? Just give you a second to think about that. And the answer is you're going to see a lot more posterior dislocations in these offensive linemen that play this position, because when their hands are up like this, they get kind of pushed back, and that's where these linemen experience these posterior dislocations, especially when they're engaged with other linemen about the same size. So it's usually a posterior dislocation. And then he asked the question of how would you manage this? And he asked me first, and he said, how would you manage this patient? I said, well, especially if it's happening, if it recurs, we probably have to get in there, and this is someone we probably have to fix, and we've got to probably do a surgery on and start rehab right after that. And the surgeon looked at me and he said, that's the answer that a physical therapist would give. Now he turns to the athletic trainer, said, what's the answer from an athletic training standpoint? And the trainer said you'd put a brace on that would stabilize them, get them through the season, manage it, and then operate them on the off season, especially if they were having a couple instances of recurrent dislocation. So it just kind of made me put myself in the shoes of another healthcare practitioner, put my brain to the athlete's mentality, and kind of made me kind of appreciate that side of things, that just don't just think as a physical therapist. What does the athlete need at this point? You're going to see a recurring theme in these cases that you'd have to consider each of them each individual case. And Alice and I were talking ahead of time, or I think it was Emily and I were talking, that I was kind of forced to be in this room here, and I realize right now we're in the same building as the Atlanta Hawks, and they are practicing right behind this wall here. I don't know if you can hear it. I can hear them practicing, so I hope you can't hear it. But yeah, so they're right behind the wall here. Okay, so case study number 2. And this is a kid I actually just I saw this morning. I've been seeing him for a couple visits, and I saw him for a little bit over the summer as well. 15-year-old high-level high school basketball player with left anterior knee pain. He's going to a prep school where they really have a heavy focus on basketball. And so he can kind of mix in some classes with his practice, which they're doing 2-a-days, and some lifting programs as well. He was diagnosed with Osgood-Schlatters with that anterior knee pain, and they told him it was just growing pains. So he came in to see me for an evaluation. Like I said, I saw him in the summer for a little bit, similar thing, and then he kind of fell off the wagon a little bit, came back and saw me a couple weeks ago, and today was his second visit back with me, where we did an evaluation, and I told him, I said, yeah, you just had a growth spurt. There probably are some growing pains, but we need to do an evaluation. And you're going to see this recurring theme with another athlete in one of the later cases, that we really do have to assess these kids, right? We can't just say, it's growing pains. Okay, you're going to grow out of it. Here's some exercises. Let's see exactly what's going on, because there's going to be some root causes of what these athletes are presenting with. And when I went and assessed this kid, he was a point guard, so he was a smaller kid, but he only had 3 out of 5 glute strength bilaterally. Right was a little worse than the left. So, I mean, the right one might have even been a 3-, that like I could put a fingertip on and cause him to break pretty easily. He had tight dorsiflexion bilaterally. I think he was only at about neutral, and his Thomas test bilaterally, his left was worse than his right. In fact, when I did the Thomas test on the left leg, which is his symptomatic leg, it did fall off to the side a little bit, which indicated that there's probably some ITB tightness as well. And when I went to put a TheraBand on just to try to challenge him a little bit, he couldn't even do that. He kind of had to work on more range of motion if we did some glute med strengthening just on the table. And I think we kind of proved to him and his dad when they came in that, yeah, we really do need to focus on some of these strength areas. And so the moral of the story is that we have to assess. You don't guess. You implement these programs. You do a pretty comprehensive evaluation, figure out where their deficits are coming from, and then you address them. And a lot of times they're going to correlate back with what the problem is. I tell patients a lot of times, you come in to see me with anterior knee pain. The knee is not often the problem. It's the joints above and below. And this is the case for a lot of different areas, right? You get a thrower that comes in with elbow pain. Oftentimes it's that shoulder that's given it's the problem, or even the scapulothoracic region. That's the problem, the glenohumeral joint, the scapulothoracic region. You really have to look at these joints above and below. So just assess, don't guess. Case study number 3. Now we're still staying in the world of basketball, and this is a real interesting case. This is a Division I college basketball player. He was a sophomore when he came to see me. And he was diagnosed with a gastrocnemius tear in the offseason. So he was here in Atlanta prepping for the NBA draft combine, doing some sports performance work. And he experienced a Gastroc tear. So the doc that he saw here with us put him in a boot, and he was seeing me for physical therapy. So this draft combine was upcoming, and so he came to see me, put him in a boot, and so we started his PT session. So we did 2 to 3 PT visits, mostly consisting of stim, ice, rest, and then we had a meeting. And this was a meeting that we really needed to sit down with the athlete, his father, who had been his national team coach from where he was from, his NBA agent, his trainer, and then it was our clinic director and myself sat down in this meeting. And we really had to talk to him about, you really have to be careful because 10 to 20% of all Achilles tears have prodromal symptoms prior to injury. That means that they're experiencing some type of pain, discomfort, swelling, something along those lines prior to that Achilles injury. And even my clinic director and I were speaking this morning. I don't know if this happened just prior to this athlete's injury, but around this time, Kevin Durant tore his Achilles in the NBA Finals after coming back off a gastroc strain tear. So I thought it happened. I thought the Kevin Durant injury happened after this. He thought it happened before. But in any case, we really had to sit down with the athlete and his father and said, look, if you go up to this combine and you go and you cause further damage, possibly resulting in Achilles injury, that is a lot longer rehab than if you just get this gastroc tear right, do the correct rehab, build your strength up, and then get back. And so what ended up happening, he went up to the combine, but he ended up just doing the interviews and did not do a workout for them. He stayed in his boot like we asked him to do and just did the interviews. And at the end of the day, he decided to go back to school for his junior season, had a very good junior season, got drafted the next year, had a decent, I want to say it was about a 6-year NBA career, playing overseas now, won an NBA championship. So I think you really have to, especially if you're a direct access clinic, you really have to know, be really frank with your athletes and just, have that background of information, evidence-based, that you're sitting down telling them what has happened to athletes in the past and what they can expect going forward, and realistically how to progress. You got to know when to kind of hold them back as well as when to push them. So the fourth study, kind of on the same realm, was a 46-year-old male with a mid-portion Achilles tear. And he came into my clinic, and this is probably going back about 10 to 12 years ago. And the athlete wanted to return to playing recreational basketball and manage non-operatively with a mid-portion Achilles tear. And this is the first time that I ended up, this is the first time I've seen an athlete come in and wanted to manage an Achilles tear non-operatively. So I said, oh, we're managing this non-operatively. So I really had to do a lot of research into this, and how do we go about doing this? And so I ended up doing a lot of research and did a couple talks on non-operative management of Achilles tendon tears after this. And so that's been kind of giving me some insight into how to manage these conditions. So considerations for his treatment plan. One, we got to know the location of the tear. It's got to be located in the mid portion of the Achilles, not the insertion. If it's more to the insertion, that's more of a surgical indication to go ahead and retouch that back down to the bone. We got to know the goals of what this. We got to know the goals of what this athlete is looking to do. So they want to get back to playing basketball, okay? So it's cutting and pivoting sport. So we got to take that into consideration with their rehab. And also you want to educate these athletes on, what does their condition look like? So 10% average loss of end range strength power with conservative management, and that's, a non-operative management. And also there is a higher re-tear rate managing it non-operatively. But he was 46 years old and did not want to have the surgery, so we managed it in this way. And so the protocol for this was we put him non-weight bearing initially in a boot for 4 weeks with 3 heel lifts, which some boots these days come with an actual range of motion measurement that you can, instead of using heel lifts, so it's about minus 15 to maybe even 20 degrees of dorsiflexion. You return gradually to weight bearing as tolerated and gradual removal of the heel lift / increase the dorsiflexion in the boot over the next 6 to 8 weeks. Initially, you're focusing on that proximal strength and no Achilles stretching for at least 3 months. I am very conservative with these athletes because you're not suturing anything back together. You're relying on the body to heal thyself. And, we've kind of heard that terminology and that you really have to be really conservative so those portions of the Achilles come back together and heal and then move on from there. Of course, with any of these athletes, we have to go through and we've got to assess and we've got to evaluate their return to sport. So there's a lot of protocols that we use as far as testing afterwards. We use isokinetic testing, we use heel rise test, we use jump movements, hop tests, vertical jumps, all these different, we've got to assess these athletes because if we can determine their capabilities and their incapabilities during their rehab, then that really helps to determine their readiness to go back to their sport. So that was the 4th case study there. Any questions at this time right now? And we'll kind of talk about this testing a little bit as we go along. Let me mute. I gotta mute this real quick. Sorry. Okay. Okay. Now the next set is, I'm going to talk a little bit about orthotics, okay? And what can we do when somebody comes in, and especially with some of these Achilles tears, you see this kind of tendency to overpronate. A lot of our anterior knee patients come in and they overpronate. A lot of our plantar fasciitis patients come in, they overpronate. Pretty common thing that we see as far as foot structure with ambulation and any type of running or jogging. And so I get to ask this question all the time. When do we add an orthotic to a treatment plan? And this is always kind of like my famous example is it's a famous athlete and we see him kind of walking on the beach here and you see that they definitely have a lower arch profile, adducted first ray, extended toes, a little bit more adduction, or everted foot. So, is this someone that we would put into a boot? And this is the foot of LeBron James, one of the best athletes in the world. And we talk with some of our sports performance specialists, and they'll talk about some offensive and defensive linemen that they've gone through and assessed, and they've seen that some of these offensive defense, they have an arch that's flat on the ground, but they're some of the best performers in the world. And so would you go ahead and correct those athletes? No, you don't really do that, because that's just how they were built and that's how they perform with that body structure. These are just some quotes that I put up here about some athletes dealing with plantar fasciitis. But what I talk to my athletes about is when you come in and you have that low arch profile, but you perform well, we're not going to change that for you because that's your performance. When do we look to add an orthotic to the treatment plan? It's when pain or dysfunction starts to rear its ugly head, okay? You can start to experience that anterior knee pain. They're starting to get more Achilles tendonitis. They've got some some glute dysfunction, some trochanteric bursitis. All those things kind of go hand in hand together. And once you start to see some of those things pop up, that's when you want to kind of think about, okay, do we want to give stability to that foot and ankle so that can ease things up the chain and make them feel better? So that's just kind of some of the things I talk about with some of the athletes as far as when do we incorporate an orthotic into a patient's treatment program. All right, let's move on. We're good on time now. So this is case study number 5. And this is a guy, I believe, yeah. So this is a guy I just discharged recently. And this is a 74-year-old, very active male, tripped and fell while vacationing. I'm trying to turn off these messages. I apologize to you guys. This is a 74-year-old, very active male, tripped and fell while vacationing down in Florida and had a subluxation of his right glenohumeral joint. Okay, so he kind of fell. This was this past January it happened. And he reported a second subluxation with an ADL about 10 days later. So it was anything traumatic. I think he was going to reach maybe overhead with something when it came out again. So he came to see me in PT about 1 to 2 weeks after that in a sling. And what should our considerations be? So this is a tough case because this guy came to me and he's been in a sling for a couple weeks. I think he was super nervous because he's active, 74, but he was active, active guy. I think he was playing some tennis at the time. And so we decided, I sat down with the doc and I made the decision. I said, we have to proceed very slowly with him to regain that mobility. I said, we're almost going to focus more on posture and some stability first. And I don't want to push that joint to be stretched out at all. I don't want to push that joint to be stretched out in the least bit. And so I made the decision to proceed very slowly with him to regain his mobility. This requires patience of the patient and of the therapist. And so you have to sit down. You have to tell them, look, we're going to proceed slowly. We're not going to push your range of motion to get back. You're probably going to get stiff, and that's a good thing. And so you have to set those expectations early on. So with his plan, he got very stiff, but eventually got comfortable coming out of his sling. But he did get, was having some pain. It was really hard to get him, to really move his shoulder because he did get very stiff. So we did get an injection about, probably about 3 to 4 months in, and that's when we start to push his range of motion and joint mobility, coupled with his strength training. So he kind of took off at that point, but he was still quite weak. Like I said, I discharged him about a week or 2 ago, so he was seeing me in rehab for about 9 months, 8 to 9 months post this fall. And he got 80-90% of his range of motion, strength of his shoulders rated at 4 to 4+ out of 5. But he even remarked on his last day, he was like, yeah, that really took a long time. And I said, yeah, it did, but I think we did the right route because I don't think we wanted to push that mobility early on. And I think if we would have pushed that mobility early on, then he would have really had that increased chance of that coming out again. And then you're looking at other things down the line. Does he need to have a surgery to fix that going forward? So successful outcomes, but again, it required patience of the patient and the PT, and we really had to set those expectations early on, like, hey, this could take a while for you to get this back. And it did, and we had successful outcomes. All right, case study number 6. So this is an interesting case that came to us. I shared this patient with another one of our therapists. He saw her for 2 visits. I saw her for 2 visits. She's an Academy Award-winning actress. That is not her in the picture on the right. Tore their ACL. She had signed on for the lead in a big active movie role. She was filming something here in Atlanta, and then and that film was starting to film in a couple months. And so it was a $50 million budget, so a decent budget for a movie. And we had to really figure out, She wanted to manage this non-operatively, okay? This is something you have to think about. If an athlete gets hurt in a team sport, it's usually, okay, next person up in that sport. But when you're thinking about something like this, where this is a lead actor in a big budget movie, if she drops out of this before everything's kind of set in place, that's pretty detrimental to that, especially if they have all their set locations all ready to go and all this money has been put in and everybody's kind of has all their commitments going on. So it's something you have to think about. And so this leads me to the discussion of something called, with ACL tears, managing non-operatively. It talks about copers, okay? And if you're not familiar with it, an ACL coper is an individual with a torn ACL who can return to their previous level activity, including pivoting and cutting sports, without the knee giving out or causing instability, okay? So there's an athlete afterwards and you might not notice that they're a coper early on. You might have to build their strength back up you might have to build their strength back up with their program and then continue to test them throughout, whether top test, strength test, vertical jump, tuck jumps, things like that. So you really need to test them out and really observe them throughout their time. I've had several copers in my career as a physical therapist, and it really depends on the activity they're going back to. A lot of times, though, you can't afford this opportunity to see if they're a coper or not. They could be a college athlete that's in the middle of their season, and to get that knee stable for their season next year, they've got to get operated on now. You don't have that window of opportunity because if you wait too long, they could miss the following year. So you just kind of have to get a feel for who your copers are. These are some of the criteria that Wellsant developed in 2018. If you ever read Lynn Snyder-Mackler's work at the University of Delaware, she's done a lot of work into identifying these copers and how to see them through on a rehab program. So these are some of the criteria that we look at that identify some of these copers. And some of the tests, that we've talked about, isokinetic strength test, hop test, tuck jump test, are some things you want to look at as far as testing them to make sure they're able to go back to these activities. So no matter what they're doing, you've got to continue to test these athletes and look at their abilities, going forward. But this was a case where it worked out well. She ended up doing the movie. She did really well in it. Got some good acclaim for it, and realized that her knee was able to take on the demands of what we were looking for her to do going forward. So it did work out well. Case study number 7. This is one of the saddest cases in my career. And I spoke to, this is Braylon Oliver. He's one athlete I did get permission to use his name for this study, and he was a linebacker for the University of Minnesota. I'll show you this video in a second. So he's a college linebacker for the University of Minnesota. In March of 2020, he sustained an ACL injury and dislocation of his knee, compromising the peroneal nerve. He had surgery, I think, about a week and a half after this injury, and came to me with 0 dorsiflexion. Knee looked great, though. This video of him is him running in the clinic at about, I think this was 3 to 4 months post-op. You could see the brace that he has on his right leg. He had no dorsiflexion at the time. He wasn't getting that leg up as high as we would like him to, but again, like as far as his knee flexion, but he did well. He did well despite that. So we had some decisions to make with Braylon. He saw me for that 6 to 9 month window before returning to school, and his knee did great, but that was not the problem. We had to really think about what was going on with his peroneal nerve and his dorsiflexion. So the treatment plan and considerations for the foot drop. We tried everything from desensitization to neuromuscular stim and other manual interventions. The sensory component started to come back, but initially the motor did not. During that time when I saw him, I was in contact with his trainer and his surgeon back at Minnesota. We really looked at what type of options. We looked at even an FDL tendon transfer to act as his tibialis anterior because that was intact, and but we decided not to do that, not to do the tendon transfer, and we decided to continue to progress him along. So he went back to school in 2021, which is 12 to 18 months post-op. I had seen some success in some literature on doing some dry needling with some E-stim, and this combined with the other treatments mentioned above started what he described as the return of his motor component. So for his last year of eligibility, he transferred to Georgia Tech. Says he never played a game without a brace, but practiced intentional movements and worked out without one when he got to Georgia Tech. So he finished his career at Minnesota. I think he had 5 years there, had a redshirt year and a COVID year, so he ended up playing 6 years in that 6th year at Georgia Tech, and started to get that dorsiflexion. Came back at about, I want to say that 18 months, 2-year mark, and that's what you'll see some of these athletes. It could take a long time for the comeback. When I spoke with him about a week or two ago, he's currently 5.5 years post-injury. He reported 60 to 65% overall movement and strength in that. He doesn't wear the brace anymore. Dorsiflexion's still weak, but he has full range of motion. He's right now the current intern strength and conditioning coach for Lamar University football team, and aspires to have his own training facility one day. I think it was the right call to let him try to get that dorsiflexion back on his own, but because there can be complications with a tendon transfer. But unfortunately, he was not able to go on to the next level. I saw Braylon when he was 13 years old for a different knee injury, and I remember thinking when he was 13, this kid was a stud, and he's going to go on to do great things. And I really think that the fact that he didn't get that dorsiflexion back till late is really kind of one of the sticking points that he was not able to go on to a professional career in playing football. But he's doing really well as the strength and conditioning coach, and hopefully kind of going forward, he can aspire other athletes. And I saw that you had a question, Allison.
Yeah, you got it. In the chat, I have a question specifically about orthotics.
Okay.
So Zach Selesnik he's the 3rd-year DPT student at the University of Findlay.
Okay.
And his question is regarding what you described for the proper use of orthotics for specific athletes. What specific impairments or symptoms would make you decide to add an orthotic for an overpronating patient?
Yeah, so, I always tell them a lot of times, we see, I'll watch, one of the first things I have an athlete do is I'll watch them walk, okay? And I will look at, what does their gait look like and what abnormalities am I seeing? And then after I evaluate that, especially if I see this overpronation, I'll look at them and I'll say, look, the body has to alternate between mobility and stability with every joint in the body, okay? And I talk to my golfers about this. I talk to my soccer players, tennis players, people going back to running. So when the foot hits the ground, it needs to be stable, okay? Heel-toe pattern, good structure to the foot. The next joint up is the ankle, it needs to be more mobile, okay? Moves in several planes of motion. The next joint up is the knee, it usually needs to be stable for some cutting and pivoting activities. And the next joint up is the hip, it needs to be more mobile. So you got stability, mobility, stability, mobility. When that foot overpronates, it throws off that whole chain, right? Because the next joint up is going to be the ankle, and it's going to get a little stiff, and you'll see some tight calves, some tight dorsiflexion there. And then the knee takes on a little bit more of a mobility function. And so when it takes on that mobility function, it's not designed to do that, right? So we see plantar fasciitis, we see Achilles tendonitis, we see anterior knee pain, possibly some meniscus involvement, tracking issues, and we see some trochanteric bursitis, some glute tendonitis in the glute when that happens. And again, I'm not going to fix these people that aren't having pain when they overpronate, but I'm certainly going to think about adding an orthotic when pain and dysfunction start to come into play. And you're going to see that, I think, on the next study. We kind of talk about that. So this is case study number 8. And actually, I reached out to her 2 weeks ago, and she said, I could use your case, but don't use her name. I said, okay. So this is an Olympic track and field athlete. She competed in the Paris Games in 2024. On her first ever attempt at her event in high school, she broke the school record. So she had some natural talent about her. And it's one thing about athletes that I've noticed in my career is that athletes can perform, right? You ask them to go out there and perform. Some of them are so naturally gifted, they can go out there and perform. But rehab's a different animal. And when they develop pain, dysfunction, even some that they need to have surgery, they don't really know how to rehab a lot of times. And so that's where they look to us for the help that they need. And we actually have to guide them. And they really, you know, as much as they think, oh, these people, they know how their body works, a lot of times they don't, right? And so we really have to really kind of counsel them on it. So she saw me about 2 years ago, complaints of anterior inferior knee pain with her specific event. Her trainer, who was training in the same facility where I work at, came over, asked me to take a look at her, and so we did. We did an evaluation, and we found a lot. She presented with some overpronation on the right grade and the left, bilateral gastroc tightness, limited dorsiflexion. She's 4- out of 5 glute med strength on the right, and you can see a lot of the deficiencies that she had coming to see us. She has tendon palpation of the VMO, patellar tendon, vastus lateralis. So we had to take these all into consideration. So the treatment plan we came up with was very multifactorial because she was in the middle of training season. I think the Olympics were, you know, they were coming up. So she really kind of had to ramp up her training, but also we had to get these symptoms under control. So she had injections with her physician, who was one of our physicians here at Emory, and we did some dry needling of the quad along with scraping of the patellar tendon. But we had to address those root issues. And so I sat down with her trainer, who I know pretty well here, and we targeted her glute strength, the eccentric quad training, Gastroc stretching, and we had an orthotic insert plan. I don't know if she went to do that for some of her runs. I didn't ascertain that, but I thought it was definitely necessary based on what we saw because she was having pain with push off. Her strength coach continued performance and strength training with her trainer after several weeks off to focus on the above mentioned interventions. So there was very multifactorial, and this goes back to the same case as the high school athlete that we talked about earlier, the basketball player, that we really have to look at some of these root issues. And if they're rearing their ugly head with these strength, flexibility, movement issues, we've got to retrain those, okay? Targeted strengthening, movement coordination patterns, flexibility. You kind of have to take everything into consideration and use that team. You know, I was able to talk with her trainer, I was able to talk with her physician, and we were able to come up with a plan that involved everybody so that we were all talking to each other and making sure that this was the right plan for the athlete. Okay, so case study number 9. This is our last one. How are we doing on time here? Yeah, okay, so about 40 minutes. Okay, so this is the last one. This is an interesting case, and this is a 60-year-old male pushed off a bar stool by his cousin's friend. Some friend, huh? And he fell on his outstretched left hand. He had a complete rotator cuff tear and an axillary nerve injury, and his X-ray also showed advanced glenohumeral arthritis. So there's a lot to unpack here. Okay, so the rotator cuff tear. Okay, we're losing stability of that ball and socket, that glenohumeral joint. Okay, axillary nerve injury. What does that affect? It affects the deltoid muscle. Okay. And then the X-ray showed advanced glenohumeral arthritis. So what are your thoughts on treatment and what would be your course of action? I'll let you think for a second here. This is a complicated case, and I really had to, this is one where we really had to sit down and go over expectations with this client. So I sat down with a surgeon and we said, this is a tough case because you have the axillary nerve injury, which affects the deltoid, the rotator cuff tear, and the glenohumeral OA, okay? So why couldn't we just consider a reverse total shoulder replacement, okay? With a reverse total shoulder replacement, we basically switch out that ball and socket joint, okay? So the ball now becomes the socket and vice versa, okay? But what makes the reverse total shoulder replacement successful? You have an you have a rotator cuff tear, you have glenohumeral arthritis. But the deltoid is really key to reverse total shoulder replacement. And he had a very much atrophied deltoid muscle because of the axillary nerve injury. So we really couldn't consider that. Another consideration would be this picture on the left is a low trap tendon transfer surgery and then a total shoulder. So basically what you do is if you look at the diagram on the left, you take the low trap down, you take oftentimes an Achilles tendon allograft, and you attach that up to where the rotator cuff would insert on the greater tuberosity, okay? And then this low trap tendon transfer would act as your rotator cuff. You would then rehab that afterwards, and then once that was successful, because of the shoulder arthritis, you would go ahead and do the total shoulder replacement. Very involved, two-part surgery with a relatively low success rate chance. So talking with the doctor, I think the best course of action was we decided to really hammer this guy's strength of his deltoid using any means necessary. I did dry needling with him with stim. I did soft tissue mobilization. I did neuromuscular electric stim, anything possible. You could kind of think cupping, other types of interventions. And we hammered this for a long time. And he kept asking me, am I going to get back? Am I going to get back? And I just kept saying, look, man, we're just doing the best we can to kind of get that deltoid back to prepare you for that reverse total shoulder replacement. After a long time, his deltoid came back. He was able to have his reverse total shoulder. And after quite some time, he's finally prospering in his rehab and back to the gym working out. And so I saw him. This has probably been a 2-year process with him, and we had to stress patience the whole time. I would bring other therapists in here to kind of stress the patients with him and that we're on the right track. And finally, a couple weeks ago, he came back in and said, I'm back in the gym. I'm doing my workouts. He's getting there. He's not all the way there yet, but I think we made the right choice, and I think it really paid off that, he can go back to doing the things he wants to do again. So takeaways from these cases: one, got to consider every patients and their individual needs. What activity they're returning to, what does their evaluation look like, what are their goals? You got to look at those three areas and really design the plan that's appropriate for that patient. Assess, don't guess. Don't think because they come in to see you, they're a high-end athlete, they're just going to get better with time or their training schedule. You got to assess them. Rely on the patient's feedback. Listen to their subjective history and their body's reactions. I tell my students when they come to see me, 80% of all of their subjective history, it's going to tell you how to drive your evaluation and how to drive their treatment plan. They're going to tell you what the answers are. You just have to listen to be able to implement that going forward. So those are some of my references. Any questions?
Kevin, I do have a question here that popped up. I think someone was thinking about it a bit from case study number 6.
Okay.
How do you determine whether this patient is a coper or a non-coper following ACL rupture? And what are the immediate priorities in the first 2 to 3 weeks post-injury to preserve function and prevent secondary issues?
Yeah, so it's a good question. If we go back to look at some of that criteria, it's range of motion and strength early on, and it's really that ability afterwards to, like, if you're challenging them in the clinic, I'm constantly asking them, does your knee feel stable? Does it feel stable? Well, it's still swollen. Yeah, it's going to be swollen. Okay, is it stable? Have you experienced any instability since I last saw you? And that's like a big key to this. They're going to get their range of motion back, they're going to get their strength. Patients are going to think they can go back to jogging, but do they feel that instability, right? What's their perception? Do they feel that instability? And that goes a long way to determine, if they could be a coper or not. Again, like I said before, we might not even have that luxury to determine it, because if they're in the middle of their season or towards the end of their season, and this ACL rehab takes 9 to 12 months, that may preclude them from next season, from being able to participate in their sport next season. So they might not be afforded that opportunity to be able to see if they're a coper or not. initially early on, you got to get that range of motion back, and you got to start to get that quad firing. If that quad is inhibited and there's still a lot of swelling around, that doesn't bode well for them afterwards. So you got to get that range of motion back early, get that extension, which in my mind is way more important than getting that flexion back. Get that extension, get that quad going early on afterwards. And I always stress to my patients, the glutes are super important in any knee rehab. So patients are almost always getting glute exercises initially, right off the bat. Anything else? Any other questions? Any comments?
Give everyone a minute to throw anything else you have in the Q&A. If you don't see it, it's up there at the top.
Is there, I'm sorry, am I?
Oh, no, not you. Sorry, Kevin. Everyone else. Yep.
Okay.
You're good. You're good.
I got you.
Nothing at the moment. Oh, we've got a live one. Let's see here. Awesome. They said thank you very much.
Oh, absolutely. You're welcome. Yeah, my pleasure. I mean, look, I've been doing this 27 years. I've seen a lot and I've experienced a lot. I'm very fortunate to be where I'm at now. When my wife and I moved to Atlanta, we moved here for her fellowship training, and that was 14 years ago. So we were only supposed to be here for 2 years, but I'm very thankful. All those cases came from Emory that I've been here. Very thankful that I've had a lot of good experiences, got to help a lot of people, and share them with a lot of students that I've had over the years.
Awesome. Thank you, Kevin.
Yeah, you're welcome.
All right. Pop back in. Well, thank you, first of all, to Kevin. That was awesome. It was nice to see a variety of those sports cases. I think that was really helpful for a lot of our students to see that and see a lot of what they're going to get into when they're out in the field. The conversation doesn't stop here. So if for those of you that are watching the recording, I know tomorrow and Wednesday is MPTE day. So a lot of you all are getting ready to take that test and maybe watching this on the other end of it. But if you're watching the recording and you have questions that pop up, please reach out to us. We're happy to have continued conversation. If you're interested in doing a rotation at any of our clinics across the US, again, reach out to us and we can help coordinate that with you. But really, really grateful. One last question, Kevin, came in here.
Yeah.
For case study number 5.
Okay.
Why must we avoid stretching the GH joint early on both for patient safety and for building trust?
Yeah. Was that the 74-year-old?
I believe so. Yes.
Yeah. Okay. Because especially if they've had that second sublux dislocation, their shoulder is very vulnerable to coming out again. So I don't take them to. I just feel like if I take them to any extreme, we're contributing to that vulnerability. I unfortunately have had to put a shoulder back in the clinic before, and I never want to have to do that again. The guy was writhing. He was laying on his back and he tried to lift his arm up in the air just to kind of test it out, and it just popped out on him, laying on the table. He was screaming. My boss had to hold him down. I had to put his shoulder back in right there and then. And it's funny, that guy goes to my church, and I'll see him every once in a while. He goes, "Do you remember me?" I was like, "I am never going to forget you. Trust me." Every time I see him, "Yeah, you remember me?" So I will remember that, and that'll stick with me. So maybe I'm a little bit more conservative because of that. But I feel like if that shoulder is just vulnerable to coming out, you got to give it its best chance to really almost like scar in and heal up. Let that capsule heal before you really push that stretching.
Totally.
Yep.
Makes sense. Thanks, Kevin. All right. It looks like those are all of our questions for the night. Again, thank you to everyone that attended and is watching the recording. Kevin, thank you for your time and your passion around this.
Absolutely.
And we will see everyone next month.
Thanks, Allison.
All right. Have a good one, guys.